Welcome everyone. It's great to have you with us virtually, online, through Zoom, and also we've got people in the room today. It's great to have people in the room. It really makes a difference, for a lecture. I was talking to Kanna about this, to have people, a live audience, so thanks for joining us. I really want to begin by acknowledging that I'm privileged to be speaking to you today from the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. And it's really an important part of reconciliation that we acknowledge the lands we're on, and I do want to pay my respect to elders past and present. I'm Joy Johnson, and I'm the president of Simon Fraser University, and I want to welcome you to the President's Faculty Lecture. As many of you do know, the President's Faculty Lectures are part of Public Square, and Public Square is a signature initiative of our vision at SFU to be Canada's engaged university. And I'm really pleased that this evening we're going to be hearing from Dr. Kanna Hayashi, who's going to address us shortly on harm reduction in an unprecedented overdose crisis. I'm really looking forward to tonight. I think we all recognize that we've had two pandemics that we've been dealing with, one the SARS-CoV-2, but also obviously this overdose crisis as well. As part of Public Square, we really look forward to providing the public and you with opportunities to hear from and engage with leading researchers, lecturers, and these lectures are really designed to enlighten and promote dialogue on important issues of public interest. This is a series of 6 lectures, and it's exploring themes of equity and justice from a variety of different disciplines. It's, I think, a really fitting topic for our time. It's one I feel personally passionate about, and I think it's a really great forum for us to share ideas and to connect. So we're broadcasting live from the David Mofagian World Arts Centre at SFU Woodwards in downtown Vancouver. And I want to thank the SFU Woodwards team for the AV and technical support this evening, and to Accurate Real Time for providing closed captioning. And for those of you who need assistance with closed captioning online, the button that you can see below in your Zoom screen. We are so happy to be back in person and online in this hybrid model for this lecture. We had returned to online only during the height of the Omicron wave of the pandemic, but it's really great to be back and gathering safely. I will ask our in-person audience, and I know you know this, to keep your masks on at all times. And for those of you who are joining on Zoom, please feel free to introduce yourself in the chat. Let us know where you're joining from. One thing about this lecture that's always so interesting is that we do have audience members from a variety of different places across Canada and beyond. For our question and answer period this evening, we're going to take questions both online and from people in the audience using a platform called Slido. And this is a site that you can easily access on your phone or on your computer. You don't need to sign up for an account. You just go to the web browser. And I'd encourage those of you in the audience to try this now, and online, try this now. You just go to sli.do on your web browser and enter a 6-digit code, and the code is here, 151020. And then you can submit your questions, and you can submit them anytime during the event. And then I'll be having a Q&A with Dr. Hayashi after her presentation, and I'll be reading some of your questions, and we'll be engaging in some discussion. I think most of you know, but I want to remind you of our community guidelines, which also are posted in the chat, and they're really about just respectful engagement with one another. The lecture is being recorded this evening, and it's going to be available on SFU Public Square website and the SFU YouTube channel. So that's the housekeeping taken care of, and now it's my real pleasure to introduce our lecturer tonight, Dr. Kanna Hayashi. Kanna Hayashi is a substance use epidemiologist, the St. Paul's Hospital Chair in Substance Use Research, and is an assistant professor at SFU's Faculty of Health Sciences. She's also a research scientist at the BC Centre on Substance Use and a Michael Smith Foundation for Health Research Scholar. She leads the Vancouver Injection Drug Users Study, otherwise known as VIDUS, a long-running study that operates in Vancouver's downtown East Side neighborhood and follows over 1,000 people who inject drugs. Her research aims to inform public health-oriented approaches to laws, policies, and programs, and thereby reduce drug-related harm among people who use drugs. So we're really looking forward to this presentation on harm reduction in an unprecedented overdose crisis. So please join me online and in the room in welcoming Dr. Hayashi.
Oh, thank you very much for the warm introduction, and good evening, everyone. Thank you for the invitation to be here today, and it's an honor for me to deliver this public lecture tonight, and on this very important topic of the time. Okay. I also like to begin my lecture by acknowledging the land on which we live, work, and play. It's the unceded homelands of Coast Salish peoples, including Musqueam, Squamish, and Tsleil-Waututh nations. And most of the research, I'm going to be presenting some of my research findings today, and most of those findings, research have been done on this land as well. And I'm an uninvited settler and first-generation immigrant from Japan. So I'm really grateful for allowing me to work here and do my research here. So today, my topic of the lecture is the harm reduction during this unprecedented overdose crisis. And I was asked to deliver this lecture with a general public audience in my mind, so that I decided to go over very basics of harm reduction. So the definition of the harm reduction, what is harm reduction, and then also talk about some of the harm reduction interventions that's been taking place in BC, especially in Vancouver, and then also talk about some of the limitations of the current approaches and what could be done in the future. So that's the sort of like outline of my lecture tonight. Okay. Joy has kindly introduced myself, but I also like to talk a little bit about more about myself. So you may be able to tell from my accent, but I'm originally from Japan, from Tokyo. I lived there for more than 20 years, and it was about 12 years ago that I moved to Vancouver to do my PhD training, focusing on harm reduction research. The reason why I came to Vancouver was precisely because I wanted to study, focus research on harm reduction, and then I knew that Vancouver is the world mecca of the harm reduction. And but for the first few years since I moved to here, I actually spent a lot of my time in Thailand because my doctoral dissertation project was taking place in Thailand. It was a community-based research project in collaboration with a group of people who use drugs there and who are operating a really small harm reduction center there. And I was basically going to the center every day and then working with those people there, peers, and who are actually trained as peer researchers. And we co-created a research project to survey people who use drugs there, and then also focusing on looking at the impact of the drug policing and the police violence on the health of people who use drugs in Bangkok there. So that was the sort of like a root of my sort of like history with the harm reduction research. But then like after that, a project has ended, and I got a really great opportunity to move my research base to Vancouver. And this is the place, like I said, that we are always looking up to, because a lot of progressive harm reduction programs are born here and almost like exported to internationally as well. So in terms of my research, I take a social epidemiological approach to my research so that I try to really look at not only the individual factors associated with people's health or health status or health related behaviors, but then also focusing on the impact of more like a social structural factors on the health of the people who use drugs. And like also, again, like Joy has kindly introduced the VIDUS project, or Vancouver Injection Drug Users Study Project. So I currently lead that project, but it started in 1996, so it's actually more than 20 years old. And obviously I didn't initiate it, but then I had an honor and a privilege to take over that project during the COVID pandemic in 2020. So that project was during the 1990s, it was launched to investigate HIV epidemics that were happening among people who inject drugs in Vancouver. But over time, the scope and the purpose of this project has expanded. So now we are looking at not only the HIV epidemics, but then looking at a wide range of drug-related harm impacting the lives of people who use drugs. And we are trying to address that through public health oriented approaches. So that's probably enough. So just a little bit about the current overdose crisis. As many of you may have seen these newspaper articles or media reports about the overdose crisis that is happening in our province. And it was actually really worsened during the COVID-19 pandemic. And it is one of the worst public health crises we are having in this province right now. And then this overdose crisis is actually more than 5 years old now. So that back in 2016, public health emergency was declared because of the rising overdose death rates in the province. So that these two graphs shows the sort of like the spike in the overdose death and the impact that is occurring in our province. So that the graph on the left side is showing that the overdose deaths has become the leading cause of the unnatural deaths in BC since around 2016, and it's still being the leading cause right now. And then the graph on the right shows the really increasing the rates of the overdose deaths in our province. And then in 2021, last year, on average, we are actually losing about 6 individuals every day because of the overdose crisis. So that it just really shows us the scale and the magnitude of the public health crisis that we are experiencing right now. And then why we are having this crisis, probably many of you may have heard, but it's primarily because of the contaminated supply of unregulated or illicit drugs in our local settings. So it's called the fentanyl, that's really the potent synthetic opioid that's been mixed with other street drugs, and that is causing the overdose deaths. So that in between 2018 to 2021, among all the overdose deaths happening in the BC, fentanyl was detected over 85% of the death cases. So that really showing that that's the primary sort of like a driver of the overdose crisis. I do substance use research, so that I do get this question quite often, that how should we tackle this crisis? And then usually people ask me about 2 approaches and contrasting them. So one is the addiction treatment and the recovery support, sort of like idea behind it is that the interventions to try to people get off the drugs or harm reduction. So that's not really force people to stop using drugs, and which approaches we should be focusing on. And I often feel that this is a quite misleading way of contrasting two approaches. And then actually, for my lecture tonight, I really want to highlight that we need kind of both approaches combined. It's not really a helpful way of looking at these two approaches and contrasting them and picking one, but we really need both. And that's the sort of like a take-home message that I want to deliver tonight. And because the harm reduction continues to tend to be misunderstood and considered a little bit controversial. So I really want to sort of go back to the basics and look at confirm the definition of the harm reduction. What is harm reduction? So there's so many versions of the definition of the harm reduction out there, but there's an international non-profit organization called Harm Reduction International based in UK, provides one version of the definition which I like personally, so I'm showing it here in my slide. So it refers to policies and programs and practices that aim to reduce the harms associated with the use of psychoactive drugs in people unable or unwilling to stop. So the last part is the most important part. We are not really forcing people or aiming people to really stop using their drugs. We are really focusing on the harms that may be occurring because of their use of the drugs, and then try to reduce that harm and really protect their health. And then the reason why we need to focus on people who are unable to or unwilling to stop using drugs, we may need to understand more about what the drug use means and what entails in a drug use. So that this is a graph taken from the World Drug Report published by UNODC, the UN organization focusing on drugs and crime. And according to them, only a fraction of people who use drugs actually need treatment. So that according to their data collected globally, among people who use drugs, only around 30% actually meets the criteria for so-called drug use disorders that require some kind of medical treatment. So that the vast majority of people who use drugs don't need treatment, so that they may not be, really see the need to get treatment. So that's one reason why we need a harm reduction approach rather than having only the abstinence-based addiction treatment approach. The other one about the substance use disorder is that there's one fact from the biopsychological aspect, which is that even if a person stops using drugs, returning to drug use is very common in their process of recovery. So that that is the fact we have to accept. And then there's also social structural factors surrounding people's lives, which is that stigma, discrimination, marginalization, and trauma often alienates people from traditional abstinence-oriented health services. That's the reason why we need a harm reduction approach here. So I want to show you one example of how the level of the people being alienated from health services. So this is the data taken from my VITUS project. And for this one, we worked with a community-based organization of people who use drugs called Vancouver Area Network of Drug Users in Downtown East Side. And collaboratively, we are looking at barriers to accessing health services, especially we are focusing on primary care services. And we interviewed 889 people who use drugs in Vancouver, and among them, 23%, almost like 1 in 4, reported that they were actively avoiding accessing healthcare because they were treated very poorly in the past. So that really shows that the stigma, discrimination, poor treatment within the healthcare settings, really, that may be induced by some abstinence-oriented approaches, is really alienating people from accessing those services. So the harm reduction is really grounded in human rights and social justice, so that it really tried to meet people where they are without judgment, without really judging bad or wrong with their drug use. It's very important, and it's the core of the harm reduction. And then because it's grounded in social justice, so it also highlights the community empowerment and engagement at its core. The most urgent priority for the harm reduction approaches is that they want to keep people alive, so, and then protect their health. Oftentimes, the harm reduction programs are really focusing on the life or death matters, so that improving the addiction treatment support, recovery support is great. But in order for people to benefit from those services when needed, they needed to keep alive to receive those services. So that's the role that harm reduction plays. And it benefits people who use drugs, their families and communities. And that's been shown by a large body of the scientific evidence. So that's the harm reduction. And then, as I said, BC is considered as a harm reduction champion, not only within Canada, but internationally, like myself, coming to Vancouver to study about harm reduction here. So again, at the core of the harm reduction, there's this strong community activism, so like born and maintained in this province, especially this is in downtown east side of the Vancouver. And the picture here shows Dean Wilson, who is one of the founders of the Bandu, the community organization of the people who use drugs, and a very effective, strong advocacy organization advocating for harm reduction in BC. And these are the people who actually really developed and scaled up a lot of harm reduction programs. For example, needle exchange programs you may have heard in the past that is really effective in preventing infectious diseases among people who inject drugs. Insight or supervised injection site is actually started by this organization, Bandu, even though they didn't have a legal permission, so that it was really born out of this peer-led services and efforts. And then now we expanded this supervised injection site to many other overdose prevention sites. The picture down there shows one of those overdose prevention sites. And then we have many other harm reduction programs in BC. So drug checking programs, naloxone distribution to really, it's an antidote to reverse overdose, opioid overdose. And then also expansion of the opioid agonist therapy. So I just want to show you one recent research findings from our research team showing the positive impact of the scale-up of the overdose prevention sites in Vancouver happening since 2016. Again, using the virus data, we are followed 745 people who inject drugs between 2015 to 2018. And the scale-up of the overdose prevention site started in December 2016. And then we compared changes in people's behavior and some potential health impacts. And then we saw immediate increase in the attendance or access to the supervised injection site or overdose prevention sites. That's probably straightforward. But then also we have seen immediate increase in addiction treatment participation. At the same time, we have seen immediate decrease in the rates of syringe sharing and public injection that is known to be associated with risk of overdose. So that it just shows that, again, really positive impact of a scale up of one harm reduction programs in Vancouver. So then, like, I talked a lot about how harm reduction is effective in promoting the health of people who use drugs. But then, like, you may wonder why then is Vancouver or BC experiencing this worsening overdose crisis despite having this a lot of great harm reduction programs. I would say, especially since 2020, there has been a perfect storm by combining the two public health emergencies, so the COVID-19 pandemic and the existing 5-year-old overdose epidemic. It's just because of the pandemic, unregulated drugs supply was getting more and more toxic with the borders closed, so that there's more challenging or difficult to get traditional street drugs coming into this province, so that drugs like fentanyl is more easily trafficked, so that you only need a really small amount so that it can be mailed to here from some other countries, so that the supply is getting more and more toxic. And the COVID-19 pandemic, affecting everyone, but then also really severely affecting people who use drugs. So there has been some service closures, and then also it disrupted a lot of peer networks as well. And then plus, there has been unmet needs of people who use drugs that's been ongoing even before the pandemic started. So I'm gonna just talk about one aspect of it, taking the example of the opioid agonist therapy. So opioid agonist therapy is previously called opioid substitution therapy. So it's considered a part of the harm reduction approaches, but it can be also viewed as sort of like an in-between harm reduction approach and a little bit more medical addiction medicine approach as well, because it involves addiction medicine physicians or primary care physicians prescribing opioid medications to people who use opioid as the clinical management of the opioid use disorder. It's considered actually gold standard of the approach to the clinical management of the opioid use disorder. And over the last few years, there has been an expansion of the opioid agonist therapies, having a wider range of medications becoming more and more available. You may have heard medications names like methadone, Suboxone, or slow-release morphine, or injectable opioids like diacetyl morphine and stuff. So our recent research just shows the negative impacts of COVID-19 pandemic on accessing one of these key harm reduction services in our settings, OAT or opioid agonist therapy. So that during July and November 2020, right, in the first year of the pandemic, we asked people who are accessing this type of treatment, OAT, about whether there was a time when they wanted to talk to their OAT medication prescriber, but were unable to. Then we found that 19%, or 1 in 5 people who are accessing OAT in Vancouver actually reported inability to talk to their OAT prescriber. And then among them, more than half of them, their inability actually increased during since the COVID-19 started. So it really shows that negative impacts of the COVID pandemic on access to harm reduction in a setting. And then also, we found that people who had the difficulty accessing OAT were more likely to have some characteristics or markers of heightened risk of overdose, and then also other health risks. For example, people who had chronic pain or mental health issues or had difficulty accessing other health or social services in general were more likely to report the difficulty talking to OAT medical as prescriber as well. So that it just shows that how COVID-19 pandemic was affecting everyone, but especially people who are more marginalized in a really severe manner. Another aspect of with OAT, again, this is another recent research findings from our team. It's actually been done pre-COVID, before the pandemic, but OAT, as I said, is considered as a gold standard approach to managing opioid use disorder. And however, some portion of the people who are accessing this type of treatment or harm reduction approaches were reporting some dissatisfaction. For example, among people who are accessing methadone treatment, about 30% were saying that they're actually not really satisfied with their treatment. And then people who were reporting the dissatisfaction with their treatment were more likely to report or more likely to test positive for fentanyl, so that having a higher risk of overdose. So that we were wondering, in this study, we didn't really ask people more details about why they're feeling unsatisfied with their treatment, but there could be a lot of reasons, and it's not, of course, it's not any single one reason, but one of the reasons could be that associated with the increasing toxicity of the unregulated drug supply in those settings. So in another study from our team, we looked at people's preference for different types of the opioids among people who use opioids, and between 2017 and 2018. And we found that there's a significant increase in the preference for fentanyl. And people who reported they liked the fentanyl most among all the other different types of the opioid said that it gives them a better high, 45%, or it lasts longer than heroin, or they feel they're more addicted to fentanyl by now. So we've been in this overdose crisis for more than 5 years, and a lot of people are taking or exposed to fentanyl for long time already, so that they maybe their tolerance for opioid has increased. So that one potential reason why some people are getting unsatisfied with OAT is that maybe the dose of the methadone or the opioid medication provided within the OAT may not be really enough for them to reduce their use of other street opioids. So that's a good a segue to a new novel harm reduction approach we may need to expand, initiate and try to evaluate, and which is the prescribed safer supply. And this approach has been approved by the BC government last year in July 2021. It's actually Canada's first permanent safe drug supply initiative. So that in this initiative, they're trying to prescribe pharmaceutical alternatives to unregulated drugs to prevent overdoses, not for the medical purposes really, for the purpose of the overdose prevention. And this is a really welcoming approach. And our research team is really planning to help evaluate this new initiative to see whether this new type of the harm reduction approaches will be effective in reducing people's risk of overdose. Another version of this safer supply approach is the one that is led by the community. So that, again, last year in October, a group of the people with living in a lived experience or people who use drugs submitted application to Health Canada to get an approval to operate the Compassion Club or community-led safer supply program in Vancouver. So the prescribed safer supply is still very medicalized model where people have to go to the clinics and then get the prescription from healthcare professionals. However, as I showed in the previous slide, quite a significant portion of the people who use drugs are actively avoiding accessing healthcare, so that as long as those new programs are offered or operated within that medical system, then some people, especially people who are more marginalized, may be having some difficulty accessing those new services, so that this community-led approach could fill in that unmet need. And so the results of the application remains to be seen, but this is an exciting sort of like a movement and upcoming like a new harm reduction approach coming to our setting. So I hope that by now I have convinced you that in order to tackle this crisis, we should no longer contrast these two approaches, but we should really combine and seek to scale up all the range of approaches to address drug use disorder in our setting. And then also in conclusion, I also want to mention that these two approaches are not the only two approaches we should be sort of like focusing on, because a lot of issues surrounding or associated with drug-related harm originated from broader social structural factors. For example, racism, gender inequality or gender-based violence, childhood trauma, poverty, housing crisis. All those things are really behind the issues of the drug use, and then oftentimes those are the issues that keep people using drugs because they need to numb their pain from those traumatic experiences. So those are the things we also need to tackle. So that's something I want to also emphasize at the end of my lecture today. So I want to end my lecture by acknowledging all the funders of the research that I presented today, and also the host institutions, including SFU Public Square, who gave me the opportunity to deliver this lecture tonight. And then also special thanks to all the study participants, inviters, and others, as well as current and past researchers and staff. Thank you very much.
Very much, Kanna. Why don't you come and sit down, and we're going to have a conversation. And I'm going to remind people about Slido, and I think there'll be information about how to use Slido. We're using Slido tonight if you have a question. I think a few people came in after I'd given that direction. And so Slido is, you just go to your web browser, and it's sli.do. And there's the information there. The code is 151020. For those of you in the room, if you need a hand, you can put your hand up and someone will come and help you with your Slido. But Kanna, that was fantastic. And I'm seeing a lot of questions getting raised on Slido already, and we will dive into those. But I want to just kind of back up first and talk a little bit about the VITAS study, because that study has been around for a long time. And I'm just wondering if you can just help me just unpack a little bit about how you, it's an open cohort study, so that means that you're looking for around 1,000 people in every intake, but you're not necessarily always following the exact same people over time, is that correct? Or how does that work? Maybe you can start with that.
Yeah, so we actually, since 1996, we actually enrolled maybe, I don't have the exact number in my hand, but maybe more than 2,700 people enrolled in this project. And then once enrolled, they needed to be injecting drugs in the past months before they enroll in our study. But once they enrolled, then they will be followed up every 6 months by our interviews, plus some blood testing for HIV and hepatitis. And then they will continue to do so until at some point they may just decide to not, interested in the study or anything. So that on average, they stay in our study for about 6-7 years, maybe.
That's incredible.
Yes, it's actually one of the highest follow-up rates we maintain compared to other similar studies in the world. And so, but an open cohort that you mentioned is that because some people may, decide to not to stay in our study, so we are also open our doors to new recruitment all the time, so that it's not that everyone starts at the same time, but we are enrolling people over time, so that at any time point, we should be seeing around like 1,000 people, or more than 1,000.
And just maybe again, in terms of just doing this research, what are some of the challenges in terms of, you talked about how people don't trust the healthcare system. Obviously, having them trust researchers also potentially could be challenging. How do you overcome some of that?
I should really, it's not really because of me, because we have a fantastic frontline research team working in the downtown east side, so that we have a frontline research office on the Hastings Street in downtown east side. And then we have a whole frontline research team really following people, interviewing people, and the nurses taking, blood testing. And then some of them are actually working there more than 20 years. Wow. So that, they have a really a strong, robust trust relationship with our participants. So that really helped us to keep people in the project, so that we are following people for a long time. And having that kind of like a really a longitudinal, like a long-term data following people's changes in their behavior gives us a really strong, globally unique database to really do any research on, substance use patterns or harm reduction.
That's great. And are you using peers as well in the study, or do they have a role to play in the research that you're doing?
Yes, one of our younger sister cohort, ARISE study, we have a team of the peer research associates, so that they really work with us and help us do outreach in the neighborhood, and also keep people, keep in touch with our participants. That's really an important aspect of what we do on a daily basis at the front line.
Right. And so we were talking before your lecture this evening about some of the challenges right now, even doing this research with COVID, and maybe just talk a little bit about that as well. It has not been ideal, has it?
No, the COVID-19 pandemic really impacting us researchers as well. I show some research findings, how COVID-19 was having a devastating impact on people's access to care, but it's also affecting us, our research as well. So since, over the last 2 years, we actually forced to follow people over the phone only, unfortunately, so that that really, our frontline team really made a great effort to try to keep people in touch with our research, but we were only able to do so by the phone. So that by default, we were unable to keep in touch with people, like a cohort participants who didn't have access to the phones, right? So we are losing, some portion of our cohort who are probably more marginalized compared to others. So that's really really negative impact we've had over the past 2 years. But we have a hope that we are hoping to do a soft opening to resume some in-person research activities later this month, and maybe, you know, becoming more fully in person over the next month or two. So hopefully we can recover from that very soon.
And when you do these studies and look at the findings, think about the implications, do you also involve drug users in interpretation or in discussions around policy? Maybe talk a little bit about how that might work.
Yeah, it depends. Like, we are not like really engaging peers in every single sort of like a studies or papers, because we actually really, VITUS is actually has two other sister cohorts that are very similar to VITUS, ACCESS and ARISE. And together with the 3 projects together, we are actually producing maybe 40, 50 like studies or papers per year. So it's just not possible to engage peers in every single paper. But we also have a lot of sort of like a sub-studies within our cohort. And like the one that I showed in the slide, there's one project really looking at access to primary care services. And for that sub-project, we are collaborating with Vandu and BCA-PON and WORS, like those 3 community-based organizations of people who use drugs in downtown East Side. So for those specific projects, we are working with peers from, you know, conceptualizing the project and designing the study questions and interpreting the data as well.
Excellent. I'm going to start to turn to the questions in a minute, and I'll remind people to keep voting up questions and put them into Slido. I just want to, again, for my own clarification, you talked about the OAT.
Yeah.
And then you also talked about the Compassion Club, but what was that? The other one is
prescribed safer supply. That's been.
And so just help me understand so that's prescribed, so it's physician delivered, and what kind of supply would be provided through that?
They're basically prescribing some pharmaceutical opioid medications that could hopefully or theoretically serve as an alternative to the street opioid or down that people are using. So that it remains to be seen exactly what kind of medications can be really prescribed within this initiative, and whether that medication has really similar effect with the street opioids that people are using. Like I said, if the opioid medication is just too weak, then it doesn't really help people to substitute their street drugs with the pharmaceutical alternatives.
Okay, interesting. And there has been, I mean, I know back in the day, there was a safe drug supply study, the Naomi trial, in which heroin was given to people, and it really did stabilize them in their lives, right?
Yeah.
So, you know, there is a kind of a proven concept here that can be built upon.
Right, yeah, that was more like a medicalized model, like that was like provided as a medical treatment, and it still continues to be provided to a small number of the people. That's the injectable opioid therapy. But in order to receive that therapy, you have to go into that clinic maybe 2 times or 3 times a day.
Oh, okay.
Yeah, so it's quite an intense form of the treatment. So that we are, I think for this more safer drug supply initiative, whether prescribed or community-led initiative, we're trying to look at more flexible approach to access those pharmaceutical alternatives, but details to be.
Well, this actually is a perfect segue then to the first question on Slido, and the question is, ensuring a safe supply of drugs is the most logical way, and you've made that case, of reducing harm in users. And what are the barriers? I mean, where to begin here, but what are the barriers in terms of really moving safe supply policies forward? What are we going to do here? What's your sense?
I think there are so many, but one thing is that we are trying to prescribe some pre-existing like pharmaceutical medications to people, not for the purpose of the medical treatment, but for the purpose of more like a public health related, like a purpose of the overdose prevention, which is something that the prescribers or healthcare professional physicians are not really trained to do.
Okay.
How to do it. Like they are bounded by their own medical ethics, so that they're trained to do no harm to their patients, but they know how to do it if the medication is provided as a medical treatment, because there's that, really rigid like prescription guidelines out there based on the evidence, but they don't have training or experience to prescribe those medications for the public health purposes. So I think that's sort of like a physician education, training, and building experience and building evidence might be one barrier or factor to think about. Yeah, probably that may be the most like a biggest barrier.
And I would think also, the Health Canada approval would be a big barrier as well.
Yeah, of course.
Yeah. And what's your sense of where that's at right now in terms of the...
I'm not really directly involved in that application process, so I don't have any real updates.
Yeah.
If anyone has updates, I'd love to hear as well.
Throw it in the Slido, that's great, yeah.
Yeah, and then another thing to like that sort of like came up when people started to really talk about how to implement this safer supply initiative is that how to deal with potential diversion of the prescribed medications, right? So we are trying to reduce the barriers to receive medications. Like we don't want people to go to the clinic 3 times per day and use the drugs within the clinic. It's really, really not flexible, right?
Yeah.
But if you allow people to take home those medications, what's going to happen? Like I think that's the sort of like a concerns that are raised by the prescriber communities, and because we don't want to increase the harm to the community, right?
Yeah.
So that's something to think about. But then we actually have an interesting recent research findings from our team about looking at actually a diversion of the prescribed opioids among this sort of like a particular group of people, like virus participants. Half of them are living in Downtown East Side. Is that it was actually helping to people reduce their risk of overdose or risk of consuming fentanyl. Because in some ways, because the unregulated drug supply is so toxic right now, so that diverted pharmaceutical opioid is actually better and preventing the risk of overdose among people using opioids in this particular setting. So, and I also remember from my old days working in the harm reduction center in Bangkok with the people who use drugs there. And then people actually do share their methadone OAT medications among their friends and peers, because sometimes they feel like, oh, I don't need a methadone like a dose for today. So for some they took some doses home so that they had a stock of methadone. And then they had another friend really experiencing that, like, opioid withdrawal. So that in those cases, they will just, give the methadone to their friends to really, help them.
Yeah.
And that way of sharing pharmaceutical opioid was actually making, again, like keeping people alive. Yeah. So that's also another reality happening in the community. But if we want to really make this intervention more official and thinking about the scale up down the road, I guess like we also need to really think about all the potential risks of the diverted pharmaceutical opioids. But I wanted to just mention that there's some recent findings that diversion is not necessarily really a bad thing, especially in the context of this really toxic drug supply.
Yeah, and we see divergence in terms of other drugs as well. It's interesting that we really focus on that. It's fascinating. This question is related to, because you really, in your answer, focused a lot on the need around medical education, healthcare education. And this question is about how do we address stigma within healthcare settings? And I do appreciate, the second part is the assumption that education alone will not cut it. So, we've got a big issue here. And I know you hear about it, and I'm just be interested in your opinion about how we might start to address that.
Well, it's, fighting the stigma discrimination is probably the most challenging and a difficult thing among others that, that I talked about, like, housing and then others. But, I think wow, that's really difficult, but we just need to continue to continue this education and training. And then I think having like a peers or people with lived and lived experiences, they're pointing to some specific examples of how, when that stigma discrimination is manifest in healthcare settings, right? Like sometimes people who are sort of like acting like a discriminating people, they are doing it without knowing they're actually doing it, right? So that, like getting some help from people who are affected by that very stigma and discrimination in healthcare settings might help. And then also there's already some efforts to include some peer outreach workers and peer navigators in sort of like a healthcare system, especially in settings like downtown east side. So that may also help. And and then one another recent research findings that I just popped up my head is that for that research project that I talked about that we are collaborating with Bandu and other community-based organizations, we are looking at a non-clinical quality of the primary care facilities or primary care settings. So by non-medical quality, we used some 7 different domains identified by the World Health Organizations, and things like respect for dignity, respect for like a confidentiality, whether that's being maintained, or the cleanness of the facility and things like that. And then one of the domains that had a really poor score on was the communication with the healthcare professionals. And a lot of people who use drugs in the VITUS project were saying that they don't feel they were actually listened to by their doctors. So that they constantly feeling that their needs are not really heard. So that may be a specific, pinpointing thing that could be incorporated in education.
Yeah, obviously a lot of work to do, and I agree. It's not simply education, but it's also modeling, and it seems, based on your example, also evaluating and identifying sites where some of these standards aren't being met. So thank you for that. Yeah.
So for identifying and then getting that knowledge, again, like, collaborating with people who with lived and lived experiences in this type of research is really important, because without having them involved in our research, then we are not able to come up with the really important questions to ask in a questionnaire.
Yeah, thank you. That's great. There's a question here specifically about the Portugal model. And so for some people, it'd be helpful for you to explain what the Portugal model is. But the question is, why do you feel Canada is not following Portugal?
I think there has been actually a recent movement, especially in BC and in Vancouver, that they're trying to follow that policy initiative, decriminalizing personal use, possession of the drugs for personal consumption. So currently, if you are possessing any drugs that are prohibited by the drug laws, even for a small amount for your personal consumption, you may get arrested and get a criminal record and everything. But what the Portugal did was that decriminalized personal drug use, so that they took out the criminal sanctions for when people are using drugs only for themselves and then having really a small amount of drugs. But the Portugal model, I think they still had some kind of like administrative sanctions for, or some conditions for when they are caught a few times, then they may need to go to some kind of treatment service facilities. But anyway, so basically that's what Portugal did, decriminalized personal drug use. So it's not a crime anymore. And then once it was done in 2001, and then since that legal change, there has been quite a lot of like a positive impact, so that there has been a decrease in HIV infection among people who use drugs, and overall decrease in drug use in their country, and there has not been a really increase initiating drug use among youth and things like that. So has been a really good, like a positive impact on their public health, on their public health. I think in BC and in Vancouver, especially during the COVID, there has been, I think they actually submitted application to Health Canada to actually initiate their own model of the decriminalization. So decriminalizing possession of the drugs for personal consumption. There has been a lot of stories to it, so that it's been all done out of the really goodwill and then really strong will to really hope to reduce the harms associated with this criminalization of the drug use. But when they sort of like sorted out the details of how much drugs could be allowed to people are allowed to possess, and then for personal consumption, there has been a lot of sort of like a conflict, and unfortunately, the people with lived experiences, so like suggestions and then needs were not really heard in their final application proposal. So that was really an unfortunate event, but I just want to note there has been a movement.
Yeah, we're not there yet, though, it sounds like.
No.
Yeah, it's so interesting, such good intentions, and yet we can't quite get it across the finish line, it seems, in terms of really moving forward with these policies.
Right, yeah.
Next question, can you speak more to the potential benefits of a combined approach, addiction treatment and harm reduction, in terms of the efficacy of treatment outcomes when recruited from a harm reduction program context? So just, I think what breaking that down is, you're in a harm reduction treatment, you might be more open to, or you might be more open to actually an addiction treatment program, I think is what's being suggested here.
Yeah, I think there has been, there's a lot of research coming out of the scientific evaluation of the Insight and or supervised injection facility in downtown East Side. And one of the findings was that people who are accessing Insight were more likely to enroll in those like more traditional type like addiction treatment, because Insight had an on-site upstairs where people actually can access some addiction treatment or detoxification services. So that I think there has been quite a lot of evidence around harm reduction programs can serve or act as sort of like starting point for people to actually access to other types of addiction treatment. But I think there's that evidence there, so that there's that sort of like, there's a mutual sort of like benefits of combining or providing a spectrum of services, both like harm reduction approach and treatment approaches there. But I also want to emphasize that whether or not person decides to enroll in addiction treatment should be really made by that person. Like it should be made, like, you know, voluntary participation is really the key, so that we should not assume that there's a hierarchy there, so that you start from harm reduction and go up the ladder to access harm addiction treatment. It's not like that. I would sort of like view those like different types of approaches more horizontally, so that people are presented with a range of the services, and then depending on where they are in their lives, there's always a door to knock on. Yeah. I think that's the model I think we should be, you know, pursuing.
Yeah, yeah. I mean, that was the original thematic around harm reduction: every door an open door, right? Yeah, yeah. It's fantastic. This is kind of a follow-up, I think, and it's based on your research. Do you think oh no, we've covered that one. Based on your research, do you think the ministry, oh, sorry, it's back. Sorry, everybody, back. 202, here we go. Is any rigorous and systematic analysis underway or planned to evaluate the impact of different entry points? And that's what you were talking about, to treatment programs, right, Hannah? Mm-hmm. Like, is there certain, to get to treatment, are there certain entry points that we should really be paying attention to? Or is it really truly that horizontal approach?
I think that it should be a horizontal approaches. And as I said, and you know, it's one of the sort of like a biopsychological like a fact around like a, you know, so-called substance use disorder is that even if you stopped using drugs for a certain period of time, you may be returning to drug use at some point. Yeah. And that's actually a common thing. So that, you know, if you're only accessing really abstinent only, like a strict like treatment, then you may just, you know, I don't want to use this word, but you may just drop out, and then, you know, the end of the story. Yeah. But, you know, I think we should have an entry point everywhere on the spectrum, I think.
Okay, that's great. Thank you. We've talked about this a little bit, but I think this is an interesting, and this is really about lived experience. Are there, other than participants in the study, is there a push to get more drug users involved in academia or in policy making when it's about and impacting them? Like, you know, is that part of the discourse, part of the thought right now, is to have lived experience be part of policy making, research, etc.?
I believe so. I mean, like I said, like, you know, I probably a little relatively new here to Vancouver. I came here like about 10 years ago, but within those like the last 10 years, I cannot really compare to 20, 30 years ago, but I feel like increasing number of the people with lived experiences are given the opportunity to get involved in a policy making process, or the process of, you know, designing some programs and interventions. For example, I'm also affiliated with this organization called the BC Center on Substance Use, and then one of the key things that the center does is to develop the clinical guidelines around treating opioid use disorder. And then when they're creating those guidelines, they were, you know, involving people with lived experiences and really determining the details of the guidelines. So I think that's a really good thing, and then we should be really doing this and then expanding this to hopefully all the programs and policy that affect their lives. Yeah. And then probably also I'm saying this because I have this background coming from Asia, where participation
Not
of people
involved.
with
Yeah.
drugs in policy making is almost
Non-existent.
non-existent. So yeah.
That's pretty, it is important, that notion of that experience, because there's so many unintended consequences you can't think about unless you have people there with that perspective.
Right, yeah.
I'm going to assume there's no one from the Ministry of Health here that's going to, or Ministry of Health and Addictions who's going to, mental health and addictions, who's going to put you on the record here. But the question really is, do you think the Ministry of Mental Health and Addictions is doing enough? And I think we all recognize 2021 was the most deadliest year to date. And, I think often it's claimed that they're doing a great deal, but, I'll say, I don't think they're doing enough. So,
I would love to share that sentiment.
Yeah.
Yes.
So what do you think they need to do more of? What's your sense of where the next push needs to be right now? It just feels quite overwhelming.
Yeah, it's really, really devastating. It's been a devastating year last year that we had the highest rates of overdose deaths. I really share the sentiment that, there has been some progress made, but it's just been too slow.
Yeah.
And we are losing 6 people every day, right? So we just cannot wait. So that I think one thing we really want to push at this time at this point in time is that like a safer supply initiatives.
Yeah.
Like we really need to speed up the process and try to find a way to make it work. And of course, it's a brand new initiative. It's never been done in any other countries. So that we need to also build the evidence and evaluate and whether that it's really effective or not. But we need to speed up that process. I think if we are to push one thing at this
Safe
point,
supply. Yeah, interesting. Someone does thank you for recognizing Vandu, and I think that's terrific because they have saved many lives. So that was just a comment more than anything. I saw this as well, and this is a question, your graphs, you had those 2 side-by-side graphs, and you saw a drop in the number of ODs and deaths in 2019. So here's the question, what happened in 2019?
We don't know, we didn't really have time to have an in-depth look into that, and then the COVID started. So, but it may be that we just lost too many people by that point, but it's really hard to say because we didn't have an opportunity to have an in-depth look into what happened behind that drop in 2019.
Right.
If it were due to some of the, positive impacts by the scale up of all the other harm reduction programs that's been taking place, that would be wonderful, but we just don't know.
Yeah, and it all got that tidal wave of COVID just buried some of those effects as people couldn't get access to other treatment, etc. Yeah, so and then the isolation as well for individuals, so devastating. Yeah, so hopefully as we come out of COVID, we will start to see some improvement as well. But obviously the push, as you've said, for safer supply is so important. So this is kind of related, and I think there's probably a lot of subtlety around thinking about legalization and decriminalization. So the question is, do you have an opinion on that? What's your thinking about where we need to go with legalization?
I always really in the group of really supporting and advocating for decriminalization, because legalization is quite a step, a further step. Canada did legalized cannabis, but the cannabis and the other drugs are quite different.
Yeah.
And then safer supply, some people say if you're pushing or supporting safer supply, you're also pushing for legalization. But I think those are 2 different things. And the safer supply is a public health initiative and a program, not really the sweep, change in the law. But yeah, I've been always like really a person who is advocating for decriminalization, because I think there has been accumulating evidence around the positive effect of decriminalization.
Yeah, it's an interesting challenge, isn't it, to think about? And I guess from what you're saying, decriminalization, that kind of approach, even through safe supply, there would always be checks and balances in terms of making sure that supply was going and being directed for public health purposes. Here's a pronunciation challenge for me. If the diacylmorphine, there we go, has more satisfaction with injection drug users, why is it not more available in Vancouver? So diacylmorphine, that is a new one for me.
Diacylmorphine, that's the medical, like heroin.
Oh, that's
yeah,
medical
that's
heroin.
the injectable opioid therapy.
Okay, thank you. I'm learning something today. That's fantastic.
We're talking about, yes. Yeah, I mean, it's the really unfortunate, and then there should be more, we should be doing more advocacy efforts around that, but it's just that it's not being produced in Canada. It has to be imported from, I think it's Switzerland, and then there has been just a lot of regulatory barriers to make it available to wider patient populations. So I know that there's been a lot of push and advocacy efforts around that, and we should really continue to do that. The way we prescribe diacetylmorphine is something also we should be really thinking about. Like I said, if you have to go to a clinic 3 times a day and inject them within that clinic witnessed, that's probably not really flexible enough to reach wider populations who may potentially benefit from that medication. So we, again, I think the issues around a diversion and stuff requires a thorough consideration.
Okay, yeah, fascinating. Yeah, there just seems to be so many impediments, right, to ensuring safer supply, but a supply also that people want. I mean, that's the point here.
Exactly. So yeah, I think there are 2 issues there, right? Like the supply itself, what kind of medications we can provide, or we should make it available for prescription, or to be offered to the people. That's one thing, like a medication themselves. Other things really related to that is that how are we going to offer those medications? Like I said, the current model is quite heavily medicalized model. You have to rely on some prescribers that you feel comfortable going to talk and see on a regular basis. And it's just that it's not a lot of people probably don't feel comfortable going to that medicalized model to get those medications. So that, we need to think both, think about more public health oriented and a peer-friendly, peer-led model to provide those medications.
Yeah, that's good. That's great. We've seen how quickly the government has mobilized to reduce deaths due to COVID. I mean, it's been very much every day announcing, many restrictions. Lots of effort has taken place to keep people safe. So the question is, why do you think the government hasn't taken the same approach to reducing deaths due to overdose?
I think that's the sort of a line that we also use to.
Very good. Yeah.
The government.
Yeah.
So I mean, exactly. So we are in this public health emergency for more than 5 years, and
doesn't feel like an emergency.
Exactly.
Yeah.
So then another emergency came in 2 years ago, and boom, there's a lot of Yeah, it's really, really frustrating, especially among people who are, working in this field, especially people working at frontline. I really share that frustrations. And then probably also I see, I am a researcher, so the role I envision that I should take in this in this state is that really to generate the evidence, like a scientific evidence and a new knowledge, to really support that advocacy efforts to make more progress and make more, interventions to address this, seriously address this crisis. And I think this, as a researcher, I think I have a role to play that, I have a responsibility, so that I'm really determined to strengthen my research and advocacy efforts.
Well, I think we really have seen that science has pushed. I mean, certainly in terms of the reduction of HIV/AIDS, science has played a key role with injection drug use, and just in terms of needle sharing and, et cetera. But there's another whole set of steps ahead of us, isn't there? Yeah. I'm going to take we're starting to run out of time. There's lots of questions still, but let's try to fit in at least two more. Do you see harm reduction approaches developed in Vancouver as being easy to transport to other areas like Thailand? You talked about how this is the Mecca. Boy, it doesn't feel like a Mecca right now, though, I have to say. But so do you think that we have lessons that we're learning here that we can share globally? And how might these approaches differ in different parts of the world? And what can we learn from other countries?
I think
big question.
Yeah. Well, I can maybe speak based on my own experience working with my Thai colleagues, including peer workers there. And, it's not easy to just like a transport or export the service model that's been that has worked in here to Bangkok, because it's a very, very different setting. But it's not as easy as that, but they can, one of the things that that really helped us and my Thai colleagues is that get an opportunity to have Thai peers, like people who use drugs, lived experiences, meet with community activists, peer activists here. And boom, that's really an amazing experience. Like they learn a lot, they share a lot, and then they're just so, I think there are so many lessons to learn from their peer-based experiences, so that may be like more like a kind of soft things that we could maybe export, import, transport across settings. It's not just easy to just replicate the same, like you can't just build another insight in Bangkok. It's just not gonna happen. But some like, I don't know, experiences, knowledge, based on the real experience here can be really shared with other peers in other settings, I think.
Yeah, there's real solidarity, isn't there, in knowing about other people's experiences and being able to share them. We've seen that in other areas as well. That's fantastic. Back to stigma. And so the question here is about whether some users do not seek help because of the stigma attached to the legal status of the drugs. So do you think is it the legal status, or are there other elements related to stigma that's causing people to not seek treatment or seek assistance?
Well, maybe I can speak based on my own research data, and that's from the Virus Project. And we actually asked maybe the same question in one of the questionnaires that we collaborated with Bandu, is that we are asking people about their experience of stigma discrimination in primary care settings. And then we asked people why they think they were stigmatized and discriminated. And then there are a few we provided a few pre-existing response options, like your drug use or home address, or the fact that you're homeless and things like that. And a lot of people checked many things, so that it's not really only the drug that is really causing or leading to the stigma and discrimination. It's often really intertwined.
Yeah.
So that it's really difficult to disentangle. So that again, like I said at the end of my lecture, we really need to also think about more broadly about social structural factors, and then those are often intertwined. Yeah. So that a lot of things are happening upstream or I don't know if it's up or bottom or it's surrounding us. But we need to tackle multiple factors at the same time. But it feels daunting, but I think that's the reality, I think.
Okay. I guess in closing, I would ask you, it's just hard work to do, obviously, and I would say quite discouraging. So what keeps you going? What gives you hope in terms of doing this work?
I think that I always being encouraged and inspired by the frontline harm reduction workers. They're really, like I said, our harm reduction service workers, they're working on really life or death matters on a daily basis. And it's just that tireless efforts and then determination, commitment, and belief in social justice, and then those are the things that really keep me going and make me feel that I also need to do my own. So need to take my own role as a researcher. What can I do as a researcher? So yeah, I think. But at the same time, yes, it's really sad and discouraging, especially when you lose really a close, colleagues and peers to you. Unfortunately, that's really happening, on a regular basis during this crisis. But I do see some hopes, and then I get those hopes from those people working frontline.
Well, that's probably a good note to end on. So it's really been a real pleasure, Dr. Hayashi. Really have enjoyed it very, very much. You're really thoughtful and very data-driven, obviously, in terms of the perspective that you're providing. And so I'm just really, really grateful for the time you spent with us. Please join me in thanking Dr. Hayashi.
Thank you very much. Thank you very much.
We're not done yet. I do want to thank again our captioners for this evening, Accurate Real Time. I want to thank the SFU Woodward's technical team for helping us. Thank you very much. At the back of the room there, as well at the back of the room, the SFU Public Square for their outstanding event organization, bringing us all together to engage and learn and keeping the connections going. So thank you ever so much. We have the last in the series of this lectures happening on March 22nd, and it's going to feature Dr. June Francis. And June is an associate professor of marketing in SFU's BD School of Business, and her lecture is going to be on becoming an anti-racist, decolonized university. What does it mean, and what will it take? Another challenging topic for all of us. I think it's going to be a great way to close out the session. Please join me again in thanking the wonderful Kanna Hayashi.
Thank you very much. Thank you, really.
Thank you. It's great.